Bismillahirrahmanirrahim. Now, now we are discussing fever with rash. It is session number 2. Previously, I have already discussed about there are fever which are associated with the rash, skin eruptions. And I already said that every infection which can lead to bacteremia or viremia or rickettsemia or mycoplasmia or fungemia or parasitemia can cause rash. But these rashes may be non-specific, which means that they are not very significant finding of the problem. This indicates that the microbes have entered into the body. But there are certain type of skin lesions which are very specific to the disease, and in these specific rashes, some of these specific rashes are symptom of the disease. For example, erythema nodosa with lymphadenopathy is the symptom of specific marker for the primary tuberculosis. It is an example. I am Professor Sayyid Ali Haidar talking to you as visiting professor of the medicine, Jinnah Sindh Medical University, Karachi. And I have talked previously also with childhood rashes, specifically very commonly occurring rashes, that is measles and general measles and so on. The clinical case has been discussed here, the history of a 5-year-old boy, no special past medical history. Low-grade fever of 38.3 degrees centigrade. It is 101 degree Fahrenheit for 48 hours. He attends the school and there was no travel history and no pets. Now, on examination, this is the vesicular type of rashes. You see there. These are vesicular. Rashes are vesicular. All are in one stage of the disease. Means that it is actually a papule first, and then it is converted afterwards into a vesicle. Means that it consists of a clear fluid all over the body. Now this is varicella, very characteristic feature of this disease is chickenpox. Varicella zoster virus, herpes virus family belongs to this. It is a DNA virus, and humans are the only natural host. Habitat is actually of this person. The portal of entry of these cases are host. It is a manifestation of the primary infection. This is the primary infection. The secondary infection comes afterwards, many years afterwards, and this is called shingles. That is herpes zoster, dermatological lesion, which is called shingles. It is highly contagious among the susceptible individuals. Secondary attack is more than 90%. Secondary attack means that after many years, it will appear as zoster infection or shingles. The contagiousity is the 2 days before to the 7 days and after the onset of the rash, and all lesions are clustered. It means about the total days are about 10 days. Now the patient will be immunized afterwards. IgA antibodies will be there, and then IgG will appear. This infection is of the childhood infection, although, but if it occurs in the adult, it will become very severe infection. It can cause complications. The age is 5 to 10 years old, peak age and peak seasonal infection, late winter and spring, and transmission is direct contact, droplet infection, airborne infection. Incubation period is 14 to 16 days, plus 10 days of the illness, and the total days is around 25 days. The clinical manifestation is prodromal symptoms, fever, malaise, anorexia, preceded by 1 day. First of all, there will be a prodromal symptomatology, that is fever, malaise, nausea, vomiting, etc. And then the observers see the rash, the vesicles appearing. How? They categorize small red papules, they become erythematous papules, then vesicular. And vesicular ulcerate, crust and heal, new crops appear after 3 to 4 days. It means they will be gone, and then again the second attack occurs after the 4 days. The primary and then the secondary. So the physician who is happy and the parents who are happy that it is gone, it's not gone. It will come after 5 days and it will stay for further 5 days and then it will go. So vesicular will be appearing all over the body after the disappearance of the papules. So all in one stages. That is vesicular eruption. The pattern of the rash beginning on the trunk, it is centripetal, followed by the head, face, and less commonly the extremities, lower limbs and upper limbs. Pruritus is universal and marked. It is itchy rash. Lesions may also present on the mucous membrane. You will see also these type of vesicular rashes on the palate. Lymphadenopathy may be generalized lymphadenopathy because the viremia will cause lymphadenopathy. Now these are some of the pictures which have been demonstrated here. Look, these vesicular rashes on the palate, on this buccal mucosa, even in the under the eyes, the red eyes you can see. Around it there are patches, vesicular patches. Complications are common, more severe for neonates, adults and immunocompromised persons. So adults will be definitely, a neonate will be more affected, and immunocompromised HIV patients, definitely the complications are more. Secondary infection of the skin by streptococci, and it is preceded by the streptococci. And thrombocytopenia and hemorrhagic regions of bleeding may occur. If it occurs with thrombocytopenia and hemorrhage, then it is called varicella gangrenosa. It is hemorrhagic rash then. Pneumonia occurs in 15 to 20% of the healthy adults and in the immunocompromised persons, uncommon in the healthy children. It is not common. But it can cause myocarditis, pericarditis, orchitis, hepatitis, ulcerative gastritis, glomerulonephritis. The glomerulonephritis, probably it is focal and is screening type of the glomerulonephritis. SNGC, that is called, may complicate. And the reactive arthritis may occur. Now it is also causing the Rh syndrome. What is Rh syndrome? May follow the varicella because the children have been given the aspirin, which is usually contraindicated. It enhances this Rh syndrome, in which you will see there is definitely liver involvement, but without jaundice. No clinical appearance of jaundice. The ALT will be raised, the AST will be raised. and also the PT-INR will be disturbed in these patients. So Rees syndrome, it's also involving the liver also, remember. In the second phase of the disease, it can cause the fatty change in the liver. The neurological complication may occur the post-infectious encephalopathy. It can cause cerebral ataxia, nystagmus, and tremors. These are the late complications also, after a month or two. The congenital infection causing the characteristic low birth weight, cortical atrophy, it can cause neonatal seizures, mental retardation, coronary retinitis, cataracts, may be possibility, the microcephaly and perinatal infection. Severe form of the neonatal varicella occurs. You have to give this person, if you want to save the passive immunization or immunoglobulins. The treatment is the symptomatic, non-aspirin antipyretics, cool bath, careful hygiene. If there is second infection, you will give the antimicrobials. Otherwise, the antiviral treatment, acyclovir, famciclovir, and valacyclovir can be given. If the rash appears, you see very early, on the third day, if it is started, it will be a good response. If you will start late, 7 days after the onset of the rash, the efficacy is not good. In our country, usually we give the supportive or symptomatic therapy. And the treatment of the varicella zoster virus infection is the type of the patient, depending upon this is written here, that the uncomplicated infection in the normal host, usually symptomatic therapy, but no acyclovir will be given here. Varicella in adolescents and adults, second household cases. Here we will use the acyclovir 80 milligram per kilogram body weight, around 500 milligram per day, 6 hourly. It is 500 milligram 6 hourly means rate hourly. It means 1500 milligram, or it may be 2000 milligram. 5 days duration. And zoster in the normal host, more than 12, you can give the acyclovir 80 milligram per kilogram body weight into 5 doses, divided doses, 5 to 7 days. And varicella or zoster in immunocompromised host, varicella pneumonia or encephalitis, the intravenous acyclovir 30 milligram per kilogram body weight per day, divided into 3 doses for 10 days. Acyclovir or paracyclovir or valprocyclovir or other antiviral agent may be used instead. But if the rash appears and you see the rash very early, start the treatment. Otherwise, after 5 to 7 days, the efficacy will be not good. The prevention is that children with the chickenpox should not return to the school until, because their infective stage, until the alveolar cycle have crust formation occurs, then the child can attend the school. Now, live attenuated varicella vaccination can be done. There is a primary prevention, is a live attenuated. So you cannot give in the patient of the immunocompromised persons. Passive immunity will be given by the, I've already said that the immunoglobulins can be given in this case. That is called the varicella zoster immunoglobulins. Can be given in those persons where the other drugs are contraindicated to save the patient. Now here, the indication for the immunoglobulin is that immunocompromisation. High risk patients, susceptible pregnant women. These are the main indications for the passive immunization. Another disease which I want to discuss is the hand, foot, and the mouth disease. Has anybody previously seen this disease, HFM disease? Yes, I have seen 3 or 4 cases of it. But I diagnosed actually some streptococcus infection. Here is that it is caused by the Coxsackie group of viruses. It is corona group of virus, RNA virus. It is A16 or enterovirus 71 and other enteroviruses. Most often occurs in children under 10 years of age. An enterovirus group includes the poliovirus also. Remember, this is the same group. Coxsackie viruses, arcoviruses, and other enteroviruses. The enterovirus group has got other viruses as well. Although the big, group is called the coronavirus group. The more frequent in summer and early autumn in temperate. It is not common disease in the winter or in the spring. Rather, it is more common seen in summer and early autumn. Those people who are appearing in the higher examinations, MRCP or FCPS, etc., should remember that this disease occurs in summer and early autumn, and it can, if it affects the elders, it is very severe disease. Or in a teenager, it is a very, very, disease of significant importance. Moderately contagious, a person is most contagious during the first week of the illness. Transmitted from person to person to direct with the nose and throat discharges. So nosocomial infection is saliva, fluid from the blisters, airborne infection, droplet infection, or the stool of the infected person. So it is a nosocomial infection and it is airborne infection. Incubation period is 3 to 7 days. Fever is often the first symptom of this disease. Hand, foot, and mouth disease followed by the blister and rash. First, blistering rashes rather. If it is a blister rash, then it is very, very, equivalent to the chicken pox. How will you, differentiate? Only here the hands are involved, the foot are involved, and the mouth are involved. No torso, no trunk, no neck area. Clinical manifestation with a mild fever, there is poor appetite. Again, the prodromal symptoms, malaise, feeling sick, and frequently a sore throat. 1 or 2 days after the fever begins, the painful sores develop in the mouth. The patient will not be able to eat. They begin as a small red spot that blister and then become ulcers. You cannot, if you are diagnosing this condition, it's difficult. Other parameters, clinical parameters, if in your mind. Otherwise, it is the same as pemphigus vulgaris, for example, or Rashes disease. There are more ulcers. In SAD, there are mouth ulcers. You know that. Arthritis are seen in these cases, reactive arthritis. They are usually located on the tongue and gums inside of the cheeks, and the skin rash develops over 1 to 2 days with flat or the raised red spots, some with the blisters on the palms of the hands and the soles of the feet. That we diagnose clinically in this case. You see here, the foot are involved, the hands are involved, the cheeks are involved. Here see the vesicular rash. It is a vesicular rash, just like chickenpox, but the distribution is very different. Complication is this: the Coxsackie virus A is mild disease, and all patients recover. Complications are uncommon, caused by the enterovirus EV70 may associate with the neurological complications. such as aseptic meningitis and encephalitis. So it can cause the pneumonia, it can cause the neurological complications. Although pneumonia is not common with this condition, rare complication, usually patient will come out very soon. Treatment is no specific treatment and no specific vaccine available. Symptomatic treatment is sufficient. The relief of the fever, aches and pain of the mouth ulcers, gogglings, antiseptic gogglings allowed. You can use the betamethasone or goggles and it will relieve this mouth ulcers. Dehydration is a concern because the mouth sores may make it difficult and painful children to eat and drink. That's why you have to give the proper hydration to this patient. It should be at least 40 ml per kilogram body weight. And in the winter it is 70 ml per kilogram body weight per day fluid therapy. Prevention is better than cure. Hand washing, frequent hand washing, the patient should be isolated. So the other schoolmates should not be involved. The patient should be isolated. And after the cessation of these eruptions, after 2 to 3 days, the patient can go. They should not attend the shopping centers, cinemas, swimming pools, etc. They should also wear the mask because it is airborne infection. And avoidance of the close contacts, kissing, hugging and sharing, you have to keep the distance. Just like coronavirus, we have suggested that about 3 to 4 feet distance should be there. Another infection which can cause the rash is meningococcal disease. There are gram-negative cocci, that is Neisseria meningitis, and transmission person to person by the respiratory droplets. Upper respiratory involved, then penetrating into the blood stream, it will cause a transient bacteremia and then go to the CNS and causing meningitis after frank bacteremia. So it could cause meningitis, that is meningococcal meningitis. Infect the blood vessel. If they are coming in the blood in a higher quantity, it is septicemia, that is. And meningococcemia or meningococcal septicemia will cause, first of all, cutaneous signs, maculopapular, early often a painful joint or a pressure point, petechial type of maculopapular eruptions, distribute at trunk and extremities, can be anywhere else. Purpura may start anywhere in the body and then spread in necrotic area. Non-cutaneous signs like altered mental state, neck rigidity, blue sky sign will be positive here in this condition. And irritability, nausea, vomiting, and unstable vital signs and seizures. It can cause the seizures as well, convulsions. Meningococcal septicemia can children ask, therefore optimal outcome requires immediate recognition, prompt resuscitation, and antibiotics should be given. And there are no now polysaccharide conjugate vaccine available against group A and C meningococcus. There is still no effective vaccine for group B. Triple vaccination is available against the capsulated organism, Haemophilus influenza, the meningococcus, the streptococcus pneumoniae. They are called triple vaccination. Should be given seasonally to avoid this problem. Clinical cases is now to understand completely. A 7-year-old boy, good general health condition, sudden onset of sore throat in 24 hours, fever, peak level 39 degree, abdominal pain, and 1 episode of vomiting, no conjunctivitis, no rhinitis, no hoarseness, no cough, and attend the primary school, no recent travel. Now this is the case which we discuss here, is the scarlet fever. It is caused by the group A streptococcus. I will take the full tutorial on scarlet fever because it is misnomer. People cannot understand, and this is a scarlet fever. They said it is an infection, that's all, on the hands of the body. But it occurs through the droplets, direct contact with the droplets, and the rashes appear in 24 hours after the fever, begins at the below ears, neck, and stomach, then spread all over the body within 1 to 2 days. Look like sunburn and feel like sandpaper. I have seen these cases many times in my life, but I still at that time was not able to diagnose because I don't know the scarlet fever exactly. It occurs in your society, but you are not able to diagnose it correctly. This is, of course, the thing. There is this: people are not interested to study or attend lectures or do not meet those persons who have seen these cases. More apparent in the skin folds or elbow, armpit, and groin area. As the rash faded skin at the tips of the lips and the fingers began to peel off. Flushed face, fever is more than 38, swollen glands at the neck, and white or the yellow spot coating on the throat and tonsils, and tongue is called strawberry tongue. Very characteristic feature of this condition. Strawberry tongue. These are the throat infection for female spots, as seen here, in the body folds like this. This is the armpits and elbows. The fragile blood vessel capillaries can rupture and cause classic red streaks, and these streaks afterwards is called the Pastias lines. These are not specific. It can have other viral infection also. They may persist for 1 to 2 days after the generalized rash has gone. It may persist. Other parts are involved here like this and this. The foot are involved, the face is involved. Rashes are there on the arms, around the face. Diagnosis throat culture remains the criteria because streptococcus A group should be isolated on the culture. Complete blood count, the WBC count in scarlet fever may increase to 12,000 to 16,000 means it is mild type of the leukocytosis. It is neutrophil leukocytosis. During the second week, the eosinophilia will develop, and it can cause as high as 20% category after the second week. So it is pulmonary eosinophilia. It is. If it is 20% means that high eosinophil count. As per definition of the pulmonary eosinophilia, which it will be justified. It is the result of this type of infection after the second week. This point is missing in the mind of most of the doctors. For example, CBC was done after 2 weeks. Although the WCB count is about 10,000, 11,000, absolute count was high for the eosinophil. They cannot understand why the eosinophil count is still going up. So it is allergic reaction or it is something else is going on for this eosinophilia. No, it is a part of the disease, and it will go off in about 1 week. It will be gone after 1 week. Treatment is the penicillin, yes, of course. It's a gram-positive organism. It is the drug of choice. The beta-lactam antibiotics or macrolides, like erythromycin, can be considered as an alternative. Another disease which is not seen by many of us is Kawasaki disease. It's characterized by the fever at least for 5 days together with the 4 of the following of the 5 findings. Remember, this disease is very important because it is a disease which is classified with vasculitis. 5 findings: the conjunctival infection, conjunctiva will be red and erythematous. There will be scleritis, mucous membrane changes, pharyngeal red, dry, crescite, lips, strawberry type of tongue, just like scarlet fever, cervical lymphadenopathy. There will be a rash of this, that is maculopapillary rash, redness or swelling of the hands and feet, generalized skin peeling. It is derma type of a rash because more part of the body is involved. Symmetrically, redness is there. It is a part of the vasculitis actually. The age is 4 months to 6 years, usually seen in these ages. Cause is unknown. Why it is important to the cardiologist? Because complications occur as coronary artery aneurysm. If it lodges as a coronary artery aneurysm, means the blockage occurs and the thrombus will form in the aneurysm. If you block the artery, little circumflex or anterior descending or right coronary artery, then the myocardial infarction will occur and the patient will die suddenly as acute coronary syndrome. Coronary artery syndrome is a very important complication. This is in the angiography, it is visible here. Although it can involve the aorta also. The prognosis is 75% non-sequel. Only 25% can cause the coronary abnormality. But without treatment, if you have treated the patient, there will be no coronary involvement. 1 to 2% mortality in the acute phase. So you give the steroids and the immunosuppressants in these cases. The typhus fever, I have seen in 1986 these cases. Those people who have migrated from Afghanistan to the Pakistan, I have seen these cases. A general term for the various arthropodic bone rickettsial infection that result in an acute fever illness is a typhus. There are many types of the typhus fevers. A rickettsia harboring louse bites a human to engage in a blood meal and cause a prebiotic reaction on the host skin. The camps and the hostages and camps and the other buildings in which these migrating people have actually they have been dumped there, and in those it can cause, it will be caused also in this typhus group of fever can occur where the louse occur. Lice. The louse defecates as it eats. When the host scratches the side, the lice are crushed then, and the rickettsia-laden excrement is inoculated into the white wound. The rickettsia travel to the bloodstream and rickettsiemia develops. And that will cause the problem now. So rash will appear, severe headache, chills, high head fever, stupor, muscle aches, swollen lymph nodes, rash as maculopapillary petechial or papillovesicular eruption. Forearm skin rash spreading to the body. First forearm, then it is spreading to the body. First centrifugal, then it becomes centripetal. Diagnostic test of the typhus fever has been including the blood test for the rickettsia. You can do the ELISA for IgG, IgM. We go for the PCR nowadays. Test depends on the type of the typhus. Treatment is specific antimicrobial therapy for effective agents. Actually here, those microbes, antimicrobes which are neglected will be used here, like doxycycline is very effective drug if used very on the correct time. And the chloramphenicol, it is again a old-fashioned drug. Chloromazidine, they are used as anti-rickettsial agent for treatment of the typhus. And these two agents are popular. Other than macrolides may be effective, possibility of it. But the thing is, the drug of choice is doxycycline. Second drug of choice is chronic fatigue. Third drug of choice is macrolides. Another disease which can cause the fever with rash is infectious mononucleosis, kissing disease that is. And it is caused by the Epstein-Barr virus, has particular tropism for the beta lymphocyte, B lymphocytes and the epithelial cells of the pharynx. It is tropism, affinity towards this. Now, transmission usually occurs by oral contact. Signs and symptoms of fever, the malaise, the tonsillo, pharyngitis in this condition. Lymphadenopathy is important here. Petechial on the soft palate will be seen. You can see the hot shimmer spots also on the palate. Splenomegaly 50%, hepatomegaly 10%. And the rash is maculopapular in 5% of cases. It may be a transient maculopapular rash. Diagnosis will be done nowadays with tests. You know that. The differential diagnosis, CB is called the differential, and ESR. Here it is the severe leukocytosis seen in these cases. It may be neutrophil leukocytosis. It may be higher than the leukomyid reaction I have seen with infectious mononucleosis. And remember, this disease can cause, they said that it's one of the cause of the chronic lymphatic leukemia in some cases. Or that chronic lymphatic leukemia also is transient, self-limiting. It is possibility. Because the liver is uniformly involved in the Epstein-Barr infection, there will be hepatitis, hepatocellular jaundice. It is a part of the disease. The test here is the neutrophil antibody test. You do the same with the infectious mononucleosis. And a test here nowadays is available as the monospot test. That is aggregated test available as monospot test. Pulmonal test was done previously, but nowadays they are doing monospot test. The treatment is medical care, closely monitor patient with extreme tonsil enlargement for the airway obstruction. And steroids in these cases are indicated for impending or established airway obstruction, which is a very good choice. When Epstein-Barr, and they relieve most of the cases. Because the specific therapy is not available. If you give the acyclovir or pencyclovir, no, it will not be benefited. The surgical care is necessary for the spontaneous splenic rupture. It's possibility in this because very, hyperplasia occurs in the spleen very quickly, which occurs in rare patient and with the Epstein-Barr virus, mononucleosis, and maybe the initial manifestation lesion. For example, a kick during the school playing hours will rupture the spleen in that person, a child. And it will become definitely acute abdomen. And they have to go for the laparotomy as soon as possible to save this patient for the bleeding, otherwise the patient will not be survived. So these are the cases which I have discussed, the fever associated with rashes, of different type of the rashes. I have discussed it in detail. Session 1 has been given previously, now it is session 2. I hope that these lectures may be beneficial. Those who are appearing in the fellowship examination or postgraduate examination or the final year students, I don't know. I have done my job. Because at one time nobody has taught us previously about these things. On the whiteboard they mark it, measles, mark it, chickenpox. They discuss. The people or students are sitting behind, they are laughing and just joking each other, etc. They said they will study in the library. But in the library you can obtain knowledge, no doubt. From the internet you can gain knowledge, no doubt. But if you do not visit the patients, you cannot learn properly. Case study should be done to understand exactly for the benefit of the end beneficiary is the patient. The patient should be benefited for your knowledge, by your knowledge. So this is a message given by me repeatedly that the patient are your examiners. They are the examiners. They will give the feedback that you know the subject well. You will help these persons by your knowledge, by your experience, by your observation. So, وما علينا إلا البلاغ. السلام عليكم ورحمة الله وبركاته.